through the next case of fluoroscopy.
Okay, good afternoon, everyone.
Okay, this case is a 45 years old
I'm Adel
lady.
Alghamdi, Dr. Nawaf will present the case.
Yeah, give us a second to present the case.
So 45 years old lady with ovarian cancer has a recurrent of the tumor with a peritoneal carcinomatosis. Post debulking surgery has a recurrent of small bowel obstruction for EUS coloenterostomy.
All right, Dr. Nawaf and Dr. Adel, mic is yours.
Hi, Saad. Good afternoon for you and for all our moderators here. As you heard in the history, me and Adel here trying to help our patient who has suffering from small bowel obstruction secondary to a peritoneal deposit at the distal jejunum proximal ileum. Despite the NG decompression and conservative treatment, there was no improvement in her clinical situation. She is still vomiting. She cannot tolerate orally. Her small bowel has been dilated up to, I think, 5 centimeters. So after multiple, discussion with the surgeon, with the oncologist, the surgeon, they said there is no clear, any chance for them to create ileocolostomy or ileocolonic bypass again. So we discussed with her the issue of venting big tube, as a decompression, so we reduce the pressure and the patient will be in TBN, or taking the US as an option and try to perform colono-enterostomy if it's clinically possible. So she agreed, and her family, for such a procedure. So, actually, when we start, usually in those cases, the challenge will happen to you. You go in unprepped colon. So keep in your consideration the difficulty of navigating linear echoendoscopy in unprepped colon with difficult angulation. So I usually examine, me and Adel, with a colonoscopy first. And if we would like to go, proximal to the splenic flexure, usually put a wire under floor and try to navigate the US through it. But unfortunately, at this case, we found a very tight stricture at the level of the left colon. So this is where we can get the small bowel, as you can see in the screen.
So do you have the endoscopy ultrasound screen?
We can, yes, now we can see the US.
So now our linear EUS is at the recto-sigmoid junction around 25 centimeter, because we cannot pass beyond this secondary to the peritoneal deposition. So now we are at the rectosigmoid and we can see a dilated segment of a bowel. So we definitely try to find a small bowel, not a colon. So to differentiate, first we can see here the folds and the hastria all over, which is connecting like a circular. We can see it here in a state of incomplete in the colon. And what we can do as well, we can use an FNA needle and do an aspiration and then an injection to see if there is a stool coming out. And then we'll see if there is the contrast delineate a small bowel or a colon before we do the coloenterostomy. So maybe we can use now the FNA, please, 19 gauge FNA needle. Okay. So we have the FNA needle now.
Saad, what do you think you and your panelists about performing it from this site? So the risk of diarrhea is still there, regardless, the site of the insertion. So can we hear from our experts what they can suggest for us?
So, yes, well, thank you for this nice demonstration. Basic things are basic. So before performing any intervention using endoscopic ultrasound, we must confirm the distance from the probe to the target lumen, as well as any interfering vessels, traversing vessels, and anything that would be an obstacle when you pass the needle through on the other side of the lumen. So I kind say that the distance there between the scope and the other side of the lumen is less than 10 millimeter, basically, and you're turning the Doppler on, so there are no traversing vessels. And I think you have enough distance to pass the needle, and even whatever, if you consider lamb's putting, is more than 3 centimeter. Moment, anything you would like to comment on that?
I think Thank you. You mentioned great things, and you guys also did a nice demonstration. One of the questions also that would sometimes come up, whether you do it freehand or over a wire. So what are you guys gonna plan to do here? Are you planning to pass a wire and do the lumen opposing metal stent over that wire, or you're just gonna inject, and once you confirm, are you gonna use like a freehand lumen opposing metal stent and place it there?
So thank you, Imad, for your advice, and Mu'min, thank you for the question. So usually I perform such cases. I mean, last year, like we have
Can I have
bypassed
another
by 2
slide?
cases colon-enterostomy. So we usually use a freehand hot lamps, hot axis or spaxis. So usually I do it once we enter the small bowel, we advance our wire and we start to deploy the axis. So the wire will be secured for any misdeployment if it's happened.
So, I mean, the other thing, what we are going to do right now, first to check, is it a small bowel or colon? So we did an aspiration, but we're going to change now the syringe. We'll get a new one just to make sure it's a bile. I mean, it's not a stool, so something.
Perfect.
Other
Meanwhile,
than
we have a
stool,
question from
just
the
to make sure
audience
small
to you
bowel, and then
guys.
we'll inject with the contrast to see it under fluoro.
Adel and Saad, we have a question from the audience.
Yes.
But if you didn't go through the stricture, through the mass, how you are below? So how you want to create anastomosis with this part if you don't go above? Because your goal is to create an anastomosis above the stricture. So if you cannot go, this is small bowel or colon, it doesn't make a difference. And this is a...
No. We are distal to the obstruction or the deposit at
So you pass through the
at
extraction.
the colon.
You
But
pass
we are above the small bowel obstruction. So this is the nice actually place to create the anastomosis.
Yeah.
So we are in dilated lobe in the small bowel, and we can bring it to a non-obstructed colonic segment.
So if I can have the
So,
camera, Imad and Saad.
Adel and
Can we
Saad.
have
So,
the camera to, can you guys see the,
yes, we can see that.
the
If I
content
make,
in the syringe?
Yeah,
So
we
we
do see-
just did the aspiration, and it's
so
a
can
green
the
fluid.
cameraman focus
So
on?
it's-
Okay. Okay.
So this
Cameraman,
is
can you
more
focus on
going
the
with
syringe?
a small bowel.
Yeah, usually the dilated segment of the small bowel will tell you that it's dilated, so it's
Right.
close, proximal to the obstruction. So otherwise, small bowel wouldn't look as beautiful of a target as that is.
Absolutely. So, I mean, that's something, if you're draining distally, that's the case if you want to do an upper GI, like gastrojejunostomy or gastroenterostomy, but if you're going to do it from the colon, you target the dilated side of the bowel, which is actually the way to go. I mean, commenting back on Dr. Momin comment, yes, I think you do have enough space to go freehand, and also the angle itself of purchase will be an ideal. So I can see that you put the needle through.
So can I ask a question?
So can we get the contrast injected?
Yeah.
This
So
is,
we are injecting
Dr.
contrast
Kahela.
now.
Yeah. And with the fluoro, we can focus on the fluoro side. Inject. I can see some
The only thing,
classification.
it's a dilated loop, so it will just take a while to...
So
to
meanwhile, we
to
have a
fill
question
up.
from Dr. Kahila here.
Well, that's it. I just want to get a roadmap because, I mean, I see the dilation. I see that, you are, at least by US confirming that you are on the other side of the obstruction. But I mean, maybe because I have an amazing fluoroscopy technician that helps me, but I definitely will inject contrast to get a roadmap.
Yeah, I think my
So now
question is
contrast
exactly the
is
same.
in.
How can we be sure that with a dilated adynamic segment like this, it's not obstructed further down? It's so still.
So the idea, now we are in the dilated segment, which is above the small bowel obstruction. So it's something proximal to the obstruction. So when we look for the CT, it's close to the left colon, rectosigmoid area. So this is a nice, actually, place to create the bypass or anastomosis between the small bowel and the colon.
Dr. Nawaf, can you not zoom out the fluoro image?
Can we get a bigger fluoro image?
Sure, sure.
I mean, we can still see an isopacific. You might need a lot of contrast to pacify that segment of the dilated bowel, but you can see the hustra, the contained contrast filling the dilated loops of the bowel. So these, I mean, the image under the endoscopic ultrasound, all of that actually is a good indication that you're on the right side of the bowel that you need to drain. Of course, you may consider using a 19-gauge needle in that case, which will be easier to aspirate, easier to inject through, and even if you needed to pass a wire, in case if you're not very sure about the free-handed technique, it will be your best choice. You can see some injection going through live under EUS.
Dr. Ayman, question?
I have a question here.
We have a question from the audience, Dr. Ayman.
What's about the risk? What's the risk about the bacterial overgrowth?
I'm going to do it with what?
Go for what?
Bacterial overgrowth. Is there any prophylactic antibiotic need to be given from time to time, or?
Yes, those patients should receive antibiotics prior, actually, and we keep them even after the creation of the
I have the needle, guys. Can I have the Axios,
I mean
please?
the future after that.
You would continue giving the antibiotic. So the audience is asking, Dr. Ayman, if you consider prophylactic antibiotics before the procedure, and you would continue giving the antibiotics for another few days after the procedure. Is that correct?
Yes, Imad. I give usually prophylactic antibiotics and then continue because the risk of, still there is a possibility of leak, both in, the stomach creation.
Right.
So
yeah.
And the risk of some spillage maybe in the peritoneum, and you may need to cover that.
Yes.
Dr. Hazem?
Yeah.
Lamps. So lumen-opposing stents.
I think we're good. Just bring me the 15.
Well, we call them lambs, but hot axis from Boston. The duck bones short. Yeah.
Beautiful demonstration, Nawaf and Khalid. Hazem here. I don't have any experience actually with coloenterostomy, but with some of the cases, the go bad gastroenterostomy, as well as some of the PEG tube that end up in the colon, sometimes that diarrhea could be debilitating. So I wonder if you guys have, especially this low into the colon. So I don't know if you guys have any experience or have any expectations.
So, as I mentioned, I usually use this colono-enterostomy as last option. So because the diarrhea is still a concern for us and for the patient. But in case patient disagree with other alternative, we can consider it. And taking in consideration the diarrhea, it can happen. So nicely, we have small case series came out from the America, I think from New York, from Kahela and his colleagues. In a 26 patient, they able to create, in 50%, I think, of those patients, colono-enterostomy, and the site of the creation was the sigmoid, and the diarrhea only was around 7% in their cases. So probably diarrhea is something, can be considered, but it can help the patient decreasing
please, and wipe.
the pressure in her abdomen, avoiding the risk of small bowel perforations, and even allowing for her to tolerate at least oral intake.
Dr. Michael is here. They're asking about your study, Dr. Michael Kahela. Retrospective, we did more than, I think, 25 cases with the clinical success is more than 100%.
So, they are ready.
So they're asking about your experience in that.
So what we are using now, we will use the lumen-opposing metal stent, hot axis with diameter of 15 millimeter and length of 1 centimeter. We did this after we ensure that tract length between the echo endoscope.
Dr. Adel and Dr. Nawaf, just for a second, we have a comment from Dr. Kahela and a question from the audience.
No, in terms of success, I think this procedure can be very successful, but you have to choose the right patients. So we were talking with Rashid, and obviously the first thing you want to do is try to see if you can cross the area, place a wire topically, and place a stent. It's for the cases where you cannot cross the obstruction, and typically in those cases you have a proximal dilation, pretty significant. So the success is extremely high in those patients. Luckily, it's a 90% and above. It works very nicely, but you need to select your patient appropriately. And one thing which is very important is this is something where you actually need to discuss with your surgeon. You need to be on board with the surgeon about this. Because if this patient might need surgery after, you don't want to mess this area up by creating some inflammation. So those are patients, typically we use it as a palliative measure.
So do you have tips or a trick?
Let's use the palliative measure.
Do you have a tips or trick to identify the anastomosis?
So did you decide which stent to place, 15, 20?
What size?
A 10 millimeter length.
A 10 millimeter?
15 millimeter diameter.
Why?
Can you hear us?
Small.
Yeah, the question is why 10?
It's very
too small, they're saying.
Well, so the length.
Dr. Adel,
So
here a question for Dr. Kahela.
Because we do have
So do you have any tips or trick to identify where is the exactly, I'm sure, above the anastomosis? Do you use NJ and irrigation to find the bubble to do, because this is really is a matter.
Yeah, so we already reviewed the images, and we know where the best target was close to the rectosigmoid. Then we do the EUS now, and we confirmed with the aspiration it's a bile, as well as with the injection contrast, it's a small bowel. There was no multiple area of obstruction in the CT. It was mainly in the proximal ileum. So whatever dilatation of the small bowel, it's actually proximal to the obstruction. So we did not dilate the segment. It's dilated by itself because of the obstruction. So we know now we are proximal to the area of the stricture.
So Dr. Michael?
Yeah, so I think one of the biggest problems about doing it from below is placing a nasocystic catheter or tube to put the distension is not feasible, first of all. And most of the time, like you were saying, there will be proximal dilation. What I like to do typically, and this is where really the side view scope is very powerful, is actually first understand endoscopically where the obstruction is, and kind of use endoscopy as a landmark to know where you end up in that dead end. So those like lesion you're not going to cross endoscopically. Once you're at the dead end, you typically with the side view scope, if you gently rotate it right and left, you're going to find a loop that is very dilated. And you puncture that loop, you're going to inject contrast. Most of the time, this is the right area where you're going to place the axios. There are some cases, especially when you have like very redundant bowel in the area, where you may inject at one area and puncture to place the axios in another area. And this is why the injection of contrast is so important, because it gives you the landmark, it gives you the roadmap.
There is no role for NJ and giving...
so Dr. Nawaf, I see you're in the segment already.
So you punctured using the
hot axios. Now we will deploy the distal phalange after we made sure we are far away down. So we can see the distal phalange deployed into the desired loop.
That looks bigger than a 10 stent. Did you guys go with 15?
20.
20.
Like yeah, so diameter is 15, but the length is 10.
Okay, okay.
So now we have the cone-shaped stent. Now we're going to deploy the proximal phalange into the scope.
So, Dr. Adel, you have the
deployed. Now we will switch to the endoscopic view. I will give you the scope.
So he did really...
So now into the endoscopic view. Can we? Do you guys see the endoscopic view?
No, we don't see the endoscopic view. We're seeing the frozen EUS picture.
Colono-enteric.
So,
do you see the endoscopic view?
Not yet.
Not yet.
So can we have please the...
Can I have a wire?
Press on Evis.
Gary, can I have the wire, please?
Audio-visual.
We have the slides.
Can we have the screen, please?
We'll yes.
Where's the cameraman?
Oh,
perfect,
yeah,
we see it.
Now we have it, so.
Okay, so now we see the lamps already deployed. So we will confirm with just suctioning, and then we will also advance the wire in just to make sure we are inside.
I can see some fecal material already had passed. If you apply some suction,
no, this is Can you take the axis,
And
please?
do you guys, did you mix the contrast with methylene blue or any kind of dye, or with just contrast, the injection that you used? Because sometimes we rely on the methylene blue coming back.
You can see the flooding coming.
You can see the bile, which is
yeah. So we can see now the bile.
Indicates small bowel and content, highly obstructed. I mean, since long time.
So can we have a balloon catheter?
That's very nice, Dr. Nawaf and Dr. Adel.
So actually, few points that if you can get the flora image as well to see the contrast drain, but they really made good essential steps in that. Like when they made the puncture, they advanced the catheter all the way to as far as they can go, so they can safely deliver the distal phalange of the stent. Then after that was delivered under EUS guidance, they pulled it all the way up until as close as possible to the wall, and then they switched to the endoscopic view so they can deliver the proximal phalange.
Yeah.
And that's the way it should be done.
It's very well presented.